do that. This is where I work. This is KK Women's and Children's Hospital. On the second level is somewhere the operating theatres are situated. We have around 11 of them, and we can open the 12th. And this is the background of Singapore. Now, she did say that I don't require introduction. Actually, that's wrong. I do require introduction. And I'm going to do that. Actually, just a couple of days ago, my son was asking me, what is the center of universe? I mean, sometimes children ask you some silly questions, isn't it? And you don't know. So I Googled it. So this is universe I found. Then, believe me or not, the next filter went on this. Let us remove the outer planets, the inner planet, sun, and the center came to Earth. So I said, well, let me find the center of Earth. What I get is this. Are you familiar with this photo? Yeah? Well, some of us are staying in this hotel. If you peep out of the window, this is what you get. Whatever it is, I did PDCC in Nizam's Institute of Medical Sciences. That was in 1994. And I really, really thank all the organizers for giving me an opportunity to be here. I was a bit emotional when I got this call. Thank you very much. You have organized this extremely well. Well, you know this what this is, correct? I mean, I expect each and everyone, apart from the boys sitting there, to know what this is. Yeah? Well, a woman having the epidural inserted, then the epidural has been inserted, started with the pump, and there's a typical epidural catheter sitting there in the epidural space. If at all someone wants to do CSE, that's what you do, the CSE. Now, as I said, we have around 11 theatres. We can open the 12th. And this scenario is not uncommon where we work. I'm sure you also will not be different. Well, I'll just give you a scenario. This is a real scenario in a way. Anesthetist was informed about a 26-year-old woman who needed to come to operating theatre for an urgent cesarean section, and the indication was failure to progress. The anesthetist, i.e. the junior anesthetist, the trainee, went to the labor ward. He examined the patient, found that she was ASA1, but also found that she was very anxious. He was extremely happy, delighted to see a small catheter hanging on there, because it also meant that less work, isn't it? There's already a ready-made epidural catheter there, sitting in situ. And he also found that she had made only one demand for the breakthrough pain, and it was completely relieved when 0.2% of ropivacaine along with 50 mics of fentanyl was administered around half an hour ago. So, well, fairly working epidural, he thought. And no wonder, I mean, when the pain was really complete, there was no reason for him not to believe that. Patient was wheeled to operating theatre when the epidural level was found to be at T10. We have a standard mixture, I'll tell you later, but we gave 15 ml of 2% lignocaine, 50 mics of fentanyl, and a bit of adrenaline and sodium bicarbonate. 15 minutes later, the level of block was assessed and was found at T8. Another 5 ml of the same mixture was administered, but it really didn't make much difference. It was still at T8. Have you come across such scenario? Yes? Yes, there are some honest people here. Well, will you allow the operation to proceed? No. Well, this is a fictitious thing, yeah? I've just put it. We also didn't actually. But yeah, anyway, the surgical team received a nod that yes, you proceed. But the financial incision was made. Patient experienced discomfort when the surgery proceeded further and complained of severe pain as the surgeon stretched the rectus sheath and was proceeding further. The surgeon was requested to stop for correct reasons, isn't it? And was given another 5 ml of the same mixture, and we waited for a few minutes, but it didn't make any difference to the level. And so the decision was taken to convert to general anesthetics. Anyone coming across a scenario? Yes, some people say yes. Yeah, including some renowned people in Mumbai. Well, the most comprehensive review of the obstetric neuraxial failure in retrospective analysis, around 19,259 deliveries, showed that the failure rate with the neuraxial techniques is around 12%. Of these, 46% became functional with simple manipulations overall 7.1% required replacement and 1.9% required multiple replacement. This was from IJOA in 2006. What can be the reasons? Can be multiple, isn't it? But for the simplicity, I've divided into anesthetic reasons, anesthetist reasons, patient reasons, surgical reasons. We all agree? Surgeon, well, sometimes we can blame them, yeah? And of course, the experience counts in all three of them, including the patient. Now let's talk about the patient factors. When I was doing my MD, that was a long time ago when I had a lot of hair on my head, there was a nice review article in 1991 or 2 about the dorsal median connective tissue band. I read that time, and I got very excited because, in MD examinations, you tell something really remote and you feel we have scored a gold medal. It doesn't happen like that, but that's what you have a feeling normally. Well, the thing is, yes, that time there was an issue about this dorsal median connective tissue band, which does not allow in some patients to move the local anesthetic where it should move. And that was one of the reasons cited for failure of the epidural. Now, afterwards, again, people looked at it and they found that they were mainly in the cadaveric studies, and the way they were studied was really wrong. So we are not too sure really whether something is really there or not. But, well, one of the things you could remember that, well, this thing could exist and this could be the factor in the patient. Epidural septi, once again, we all have heard about them, and this especially happens when you have got a past medical history of low back pain. And the reason is that you get some small microtraumas, and that gives rise to inflammation, that gives rise to fibroblasts raiding there, and can lead to some, microsepti or really some septi, which does not allow the local anesthetic to dissipate any further. If you had a back surgery, you certainly will have fibrosis, and, certainly you may have problems if you have got only epidural sitting there. Now, what could you do? Well, if you had a previous operation, you could insert the epidural catheter 1 or 2 levels above the upper level of the incision and hope that it gives the local anesthetic and does not, everywhere it dissipates and there's not much of epidural fibrosis, just hope. But really, you may not win in such cases. But what can help is, I'm saying what can, I'm not saying necessarily it will help. Actually, I don't have answers to everything. Certainly, even if we go through all the literature, we still will come across some scenarios, some situations where epidural doesn't work. Yeah, so that's why the topic is actually to minimize. Yeah, it's not to eliminate. When we started the topic, yeah. What concerning CSE? How many of you do CSE? Yeah, quite a lot, yeah. Yeah, because I think Dr. Shilpa was mentioning about it in one of her studies, I think Capillo study, yeah? That theoretically, when you do a CSE, there's a small hole in the dura, yeah? Capillo study used 0.25% bupivacaine, but there's a small hole in the dura, and it might be actually that in that hole some anesthetic in the epidural space seeps through it and may give analgesia at the spinal level. Really, it's not really proven, but yeah, you may want to consider CSE. Certainly, CSE will provide a better kind of analgesia, and no question about that, it will provide a better kind of sacral nerve root block. Now, subdural placement of the catheter must be borne in mind, because in a case that when the block is inadequate or patchy, it will always be the good idea to replace the epidural catheter, and should it be in subarachnoid space and should it get displaced into the spinal space, you are calling for problems. We all come across this, don't we? Over-anxious patient? Yes? Actually, we always blame the patient. Most of the time we do. That, patient was so anxious, you see, my block was at T2, C7, she actually was not able to breathe even, but still she had pain. Very anxious patient. Okay, anyway, quite a common scenario. Patients actually fear, irrespective of what you tell them before, that look, I'm going to give epidural, you may have touch, you may have a little bit of pulling and pushing sensations, but patients, if they are really anxious, they don't want to do nothing. So they say, I have got pain when I have got touch. So that's something you should take into consideration as well. And it will be worth mentioning that loss of sensation to cold with low dose epidural infusion does not guarantee painless incision. Yeah? I mean, I'm sure all of you know that you cannot carry out a lower segment section with low dose epidural or walking epidural, whatever you call 0.1% bupivacaine or levopivacaine or ropivacaine with 2 mics of fentanyl in that. You cannot carry the LSCS with that. It doesn't give you adequate visceral pain relief or adequate even the parietal peritoneal pain relief or rectus sheath pain relief. It comes much higher from that. Well, of course, I mean, you are going to have a good rapport with the patient, and as Dr. Bill Kamen was mentioning, that he introduces the patient and says that I'm Bill Kamen. Well, I also do the same really. I don't say I'm Dr. Sandeep Kulkarni because my surname is a bit too long to pronounce. So I just say I'm Dr. Sandeep, and yes, I'm going to be your anesthesiologist, and I'm going to look after you. Definitely, I mean, patients do feel, I mean, you really actually get that patient listening to you, and more than not, if the patient lands into the section, you are going to anesthetize for the section as well. So the patient already starts believing in you. So it's a good idea to have a good rapport with the patient. In spite of that, you have a patient who is over anxious, you are convinced, 100% sure that your level is at T2 or say C7. I mean, the hands have gone numb now. And still the patient says, no, I've got pain. Well, you might want to consider some Entonox before the baby comes out, or even after that, or maybe even midazolam after the baby comes out, especially, or some small dose of propofol after the baby comes out. We actually have antenatal classes in our hospital. I'm sure most of you also see the patients before they go actually in labor, and you insert the epidural, or even if you don't, you do give them some education regarding the labor pain and various options of the labor pain relief you have, and what to expect if you have an epidural. And same is true when the patient lands up in operating theater for LSCS. It's actually, when the patient comes to the operating theater, I always tell them that, look, I cannot guarantee that you will not have any pain. Actually, more often than not, you are going to get the pain of the stretching of the rectus sheath. I mean, I may not require to say rectus sheath, but actually they feel happy that they'll listen to some medical term. They get a placebo effect. So I tell them, you may get some pain of the pulling pain of the rectus sheath. Also, there'll be a pushing and pulling sensation on your tummy, and especially the baby comes out. And they also tell them that you may have some nausea, you may even have some vomiting. I mean, I don't go on to tell them that your blood pressure is in the boots and all, but I mean, these things can happen with the uterine eversion also, and many surgeons actually take the uterus out. And when that happens, I mean, it really gives you some bad feeling, yeah? I mean, some people get a vagal pain, central pain, very difficult to control. If you have got a good rapport, you've already educated the patient, rarely patient will demand about general anesthetic. Having said that, your block really should be at least at T2 level. Now, these are the variation factors. Now, let's go up to the anesthetist now. You all put the catheters. Where do you place them? Well, you obviously place them in the epidural space, correct? I've taken into consideration that we have got the catheter in the epidural space. But how much do you want to keep in the epidural space? Is it 1 centimeter, 2 centimeter, 3 centimeter, 4, 5, 6, 7, 8, 9, 10, or a foot? The answer to that is, well, I mean, most of us put between 3 to 5. I actually put at 4. Because whatever said and done, yeah, the laboring woman, they don't want to just lie in the bed like that. They want to move around. They want to, obviously, we don't allow them to go shopping, but we do allow them to move around. And by doing so, maybe the catheter can come out. So reasonable that we don't want to put less than 3 centimeter, less than 4 centimeter. And the chance of the catheter coming out of the epidural space might be less. At the same time, if you put a longer length, more than 5 centimeters in the epidural space, you might cause problems, because if you consider your anatomy, most of the time when you put the epidural in the epidural space, it does not stay in the center, it actually goes to the side. But the idea is that if it is not too much to the side, it doesn't go out the paravertebral space, out of the foramen, because that can happen. The epidural is going to find this, catheter is going to find the path of the least resistance. So if you've got too much in, then it can go out of the paravertebral foramen through the intraneural foramen. And what you will get is paravertebral block. So you don't do that. Having said that, some people might argue that, well, they have never got any problem, even if they have put an epidural foot inside. I don't have any answer to that. Now, if you had a blood tap performing an epidural catheter, it could potentially lead to blockage of epidural catheter, isn't it? Blood is going to clot. It may potentially block the catheter. And what will happen is that if you are called to the labor ward that the epidural is no more working, you want to now give a test dose, you want to really see, when you put some, say, 3 ml or 4 ml, 5 ml of, say, your local anesthetic, you're going to get a very high pressure. If the patient is already on the infusion pump will give you a high pressure alarm. And same problems you'll encounter with the kinking of the epidural catheter or not of the epidural catheter. What do? Solve the problem, correct? If required, if you feel that, well, there is no kink, your epidural still looks to be in place, i.e. say 4 centimeters, well, you may need to put the epidural catheter. Now, I'm not going to go into debate where you put in the same space or one space above, one space below, but what I mean is that you need to put the epidural catheter. In a nutshell, what do you do? Well, important to note the number of top-ups you have required to give for the breakthrough pain. Well, I mean, if you have, it's very clear, it is not rocket science to say that if you have had, say 10 breakthrough pains, yeah, you have, obviously your epidural most likely is not working. So, well, note down the number of pain. When the patient comes to the theater, well, on the anesthetic chart, anesthetic record, see how many times she required a breakthrough pain and how it was encountered with. Inspect the catheter, whether it has got any disconnections, kinks, obvious obstructions. What's the length of the epidural catheter remaining inside? See the site of the epidural catheter. Turn the patient, see whether there is any pool of local anesthetic there or pool of any fluid there. Because if you have seen a pool of fluid there, almost certainly your catheter is leaking, your local anesthetic is not going exactly where it should go. If you have got a patchy block, asymmetric block, after you have been convinced that your catheter is in place and you are okay, then you may want to tilt the patient on the same side where you don't have the block, isn't it? We all do that. This is from our actually basic teaching, isn't it? Now, what epidural top-up you give? The choice of local anesthetics? Well, 2% lignocaine, 0.5% levobupivacaine, 1% ropivacaine. For the emergency section, I would go for 2% lignocaine. And I do add additives, especially fentanyl, adrenaline, sodium bicarbonate. There were a few talks about the clonidine and neostigmine. I haven't used clonidine or neostigmine for LSCS. I have used clonidine for labor pain relief, but not for LSCS really. Always check whether your catheter is in the intravascular space or in the intrathecal space. Low dose epidural hardly will ever give you 0 out of 5 as motor power. Means the patients will be able to move the limbs. The Bromar score may not be exactly 0. It may be 1, 2, but it will not be 3 with low dose epidural. They will be able to bend their knees, they will be able to move their hips, and they will be able to raise their legs. If you are got with a low dose epidural, if your patient cannot move the limbs, well, most likely your catheter has gone into the cerebroarachnoid space or in the intrathecal space. This is important and worth noting when you are trying to give the epidural top-up. What is the mixture we use in our hospital? We have 20 ml 2% lignocaine vials. We add 50 mics of fentanyl to that. We add 2 ml of 8.4% sodium bicarbonate, 1 in 200,000 of adrenaline, and we give around 15 to 20 ml in the incremental mixture of incremental doses. This is what is a standard in KK. Now, more than not, in future, we are going to come across these kind of patients, morbidly obese patients. You may have a mini elephant landing there, mini whale, well-fed patient. Difficult to identify the landmarks. So what will you do? Well, you might want to use ultrasound, isn't it? You can see the structures, you can know the exact depth of ligamentum flavum. You may want to use this make the use of this technology. Because if you go blindly, you first of all don't know whether you're in the midline or paramedian. And if you are in the paramedian, which can happen, and you hit the transverse process or lamina, And you may get a loss of resistance, but where you are in the paravertebral space, you're not in the epidural space. And that's why, I mean, some studies say that if you are in doubt, then you put a CSC and then see if the CSF starts flowing out, then almost certainly you are in the epidural space. Having said that, we all know that there's a dry tap, and if you're paramedian, then CSF may not flow. But anyway, may worth using ultrasound. Everyone come across this? Yes, definitely. What do you do about that? Well, you try to, sometimes you can't win, you can't change people. But, well, you try to educate them, yeah, that local anesthetic doesn't work within seconds, yeah. It will take some time. And the reason you add sodium bicarbonate to 2% lignocaine is because lignocaine works faster. Well, I think in America they have got chlorprocaine, but I don't know whether it is used epidurally. I think it is, but I'm sure it is not available in Singapore. I don't know the situation in India, but if you have got chlorprocaine, well, you can use, but you must remember that it has got a very short action. Unless you have got a super fast surgeon, you may not require another dose of chlorprocaine, otherwise you are going to require chlorprocaine again. Anyway, you must tell them that local anesthetics have some time to work, and you need to give adequate time for it to work, otherwise a completely fully working epidural, you will label as a not working epidural, anesthetists will lose the job. The first, the foremost, the topmost reason of litigation in America, although I've never worked in America, but I've gone through literature. Oh, I think I've already passed time, is it? Okay, I'm a bad surgeon. Oh, I'm a normal surgeon, that means I've passed time. Will be very short. That if you have pain at the incision, that you get litigated straight away. And the second is, I think, PDPH. And always test the block height before you give the knot to the surgeon. Local anesthetic batch worth to consider that sometimes you may come across a batch where the local anesthetic already has expired, the expired date has already passed. I mean, this happens, yeah. And if it is a batch which is suspicion, like you come across 5 in a row in the same operating in the same hospital in different operating theaters, that everyone has given bupivacaine or levodopa and it's not working, then probably it might be a suspicious batch. You might want to think about it. Well, thank you. You all know who is she? Would you be happy to do that? To her, yeah? Okay, thank you very much.